Welcome to RetinaRA.org, a vitreoretinal knowledge-sharing platform. This video will present a case of a tightly adhered epiretinal membrane and pre-existing retinal damage. Which would you prefer, peeling or not peeling? I am Dr. Jirey Ersoz, the co-editor of RetinaRA.org, and this case is from my archive. The patient had a complaint of decreased vision in the right eye for the past 2 years. In some other clinics, he was advised that vitrectomy surgery might be risky and post-operative vision could potentially worsen. When the patient presented to us, his visual acuity in the right eye was 20/50. He also had a very mild cataract. As seen in the color fundus photograph, there was significant tangential macular traction, particularly at the temporal side. And face OCT demonstrated this remarkably well. It clearly showed the contraction of the epiretinal membrane, distortion of the retina, and traction-related retinal damage. B-scan OCT shows us the loss of foveal depression due to ERM. In the upper scan, the posterior hyaloid appears attached to the optic disc. The lower OCT scan shows that the posterior hyaloid remains attached to the retina in the temporal macular region, where the retinoschisis appearance and the pre-existing damaged retina were present. In the upper OCT, marked thinning of the temporal retina was visible. Disruptions were observed especially within the retinal nerve fiber layer and the ganglion cell layer. Surgical planning was based on the preoperative OCT findings. The posterior hyaloid should be separated carefully from optic disc and temporal retina, where pre-existing retinal damage is present. As shown, I was able to elevate it smoothly without inducing significant damage. I prefer using dual dye for staining, which I typically apply for 45 seconds. A key tip for starting the peeling process. I follow the shadow of the forceps on the retina in the area where I will start peeling first. Remember that the retina is transparent and the reflex you see belongs to RPE. Guided by the OCT findings, my surgical strategy was to initiate membrane peeling from the side opposite the region of pre-existing inner retinal damage. If I had initiated peeling from the free edge of the membrane, I would have caused iatrogenic peeling of the retinal layers along with the membrane, because there is a firm adhesion between the ERM and the underlying retinal layers at the free edge. In regions where traction was excessive and the membrane appeared tightly integrated with the retina, I avoided aggressive peeling. In such cases, when I observe the resistance during peeling, I often move to another area, continue peeling there, and later return to the previous site. With the time, the interface between the retina and membrane becomes increasingly hydrated. This hydration allows subsequent peeling after a brief interval. It is crucial not to persistently apply traction at the same point. As demonstrated in the video, there were moments that I grasped the membrane, recognized excessive retinal traction, and released the membrane. The primary objective was to avoid inducing tractional injury. Because I use the pinch and peel method in ERM cases, both ERM and ILM are usually peeled together. However, even if I suspect the ILM hasn't peeled, I don't attempt a second staining or peeling. I believe a second peeling procedure can damage the retina if the ILM and ERM aren't peeling together. Eventually, I discontinued peeling in areas where traction remained too strong. Using the cutter of the 25-gauge vitrectomy probe, I trimmed and relaxed the residual membrane edges, then completing the surgery. Attempting complete membrane removal in severely damaged regions could result in further retinal injury and visual field defects. Moreover, excessive manipulation might provoke more aggressive epiretinal membrane proliferation post-operatively. And always remember Voltaire's words, "Perfection is the enemy of good." 5 months after surgery, restoration of the foveal depression was observed. Even in the temporal macular region where a portion of the membrane was intentionally left, the retinal architecture showed a significant improvement compared to the pre-operative state. Visual acuity improved to 20/20.
You can share your interesting and educational cases on our website, retinara.org. Don't forget to click the like button and follow our channel to be informed about our new posts.